Hello and welcome to your IV fundamentals training. We're going to be going over IV documentation, preparation, common technical errors, and we're going to do a live demonstration for you on a person. Let's jump right in. Talking about documentation, you're going to be in your PCR on New World, and you're going to go to the interventions and then the procedures tab. You'll hit new, date and time, priority EMS care, like normal, if it was, if it wasn't. And you're going to have this whole section down here under V. VA stands for venous access. We have IOs. Blood draw is one we see a lot. Shouldn't be used very often. We only use blood draw if that's all that you did, and that's almost never the only thing that we did. Usually we catheterize as well. So typically don't use that. We have central line maintenance. Occasionally we'll discontinue a line in the field for some reason. You could document that. EJs, existing catheters, some subclavians, and other things we won't be doing. So the one you'll almost always want to use is VA extremity, venous access extremity. Now, this is one that gives some confusion, and so we're hoping to clarify that. Attempts should always be one because you're going to document each attempt at the IV separately as a separate procedure. You're going to document the size of the equipment, whether it was successful or not, and then the response. Typically, that's unchanged with an IV since it's not really an intervention that's intended to merit a response. You'll put the name of the person who did it, the type, any complications that you might see, bleeding, none, whatever, what have you. Vascular access site, that's fairly important. Left AC seems fine, and authorization. Those are typically protocol. You can do a physician order if you have some sort of a specialty. If you did something strange, like with the central line, and you talk to a physician about it, you could freeform the name in. That's fine to do. And this is a new thing. The IV tab, which we used to always fill in, we're not going to fill in anymore. So you don't need to put anything in here. It's not required. You can put some notes if there's anything you want to know about this, but I really recommend that anything you would put in notes, you should put in your narrative. Specifically, anytime you do a blood draw, you should note that in your narrative because blood draws are something that can get a little legally sticky at times. So I really recommend that you put your blood draw documentation in the narrative. And that is how you're going to document your IVs. So to give you a little example of what this looks like with multiple IVs, so that, let's say this first one was a one attempt, but I was not successful. Whoops. All right, well, now I need to do another one. Extremity, again, always one attempt. My partner's a little more ambitious than I am. Warner tries it, he misses. He shot at the antecubital right. So now we've blown both the ACs. Man, terrible. Now your third one. Luckily, we have Chief Roman to help us out with these types of things. And he somehow managed to get it in the right hand. Amazing. So that's what that should look like. You can see no, no, and yes. The reason we're doing that is for clarity of the data and also so that people aren't getting dinged when they didn't miss it. If we were to have done something like this instead of these two, Thad would have 2 missed attempts here, even though he was the one who was successful. So that's why it's important that each IV attempt is documented separately in the procedures.
Hello, this is CRFR's demonstration of initial IV start on a patient. This is a refresher for most, and some of you this will be a new skill. So get right to it. A couple of different demonstrations today. Firstly, we're going to use a mannequin, and keeping it real, we have our live stuff here, and we're going to do initial setup. So the most important part of an IV is being ready to start that IV, and that is your setup of your skill. Everything is contained efficiently in our IV rolls. So before you even worry about the patient, you know you're going to start an IV on this patient, we want to get everything set up for that patient. So we have our IV start kits. We want to open those using a perforated bag, fix everything neat, get our area, roll it out. We have our tourniquet, our 2x2, our Tegaderm, our towel, and our tape. First thing we're going to do is identify on the patient which arm we want to use to start. And I always stress start high on your tourniquet. We'll get that on good and tight. Just tighter is always a little bit better, so we can get a good fill on these arms. Okay, while the arm is being filled with blood, we get the rest of our IV set up. Start with our Tegaderm. Open it out of its protective barrier, and we want to start. Just pull back a little so it's ready for you. We're going to get our tape ready to go. Always difficult to do with gloves on. And we want to open our alcohol swab, which this kit currently didn't have one, so we'll get one of the spares out of the kit. And lastly, we want to make sure that we're getting our blood draw set up. We should be trying to start blood draws on every patient. So we have our buff cap and our hub. And we can pre-assemble these so we're ready after we start the IV. All right, come back to the arm. We look down the arm, we got a nice fill set. We want to start low in anticipation. Very, very important skill is to move the patient to make the IV successful as much as possible. I know sometimes we're in tight spots and that's not an option, but the more we can move the patient to make it easier for the provider to start the IV, the better. All right, so look at IV. We got some really good IVs on this mannequin, so I'm comfortable with an 18, though for training today we're going to use a 20. So identified my 20, it is a 20, it's pink. We remove the protective cap. We can make sure the catheter is loose on there. I'm going to apply our alcohol swab. And remember, it's always an aseptic technique. We make a nice little small circle, we circle out from there. Once we're comfortable with that, we got our needle. Remember, bevel up. Good traction is always gonna be your friend. In the hand, we want to, as low as we can, we pull the hand back in the flexed position. We'll demonstrate this better on a live patient in a few minutes. Once we have the vein visualized, we want to start at a good 45-degree angle away from our thumb that we're pulling traction with. We advance in to we're in the vein. We flatten ever so slightly, and we want to push the catheter into the vein while holding the needle in the same position. Once we're in, we occlude above the 1.25 inch length of the catheter so we have good blood stoppage, and we pull the flash chamber back until it clicks, and then we remove the flash chamber and needle from there, and we sharpen it in a sharps container, and we grab our hub, our buff cap, and we put it onto the patient, and we hold in place manually. This is my technique to hold it manually in place while I'm getting my bloods drawn. First blood always is red. Second is blue. Third is green. And the last is lavender. Once those are complete, we can remove our blood hub, and we can take our Tegaderm and secure it to the patient. This is an initial securing device. I always recommend tape, never circumferentially. And if we're adding a hub or an IV line, to use that tape in loop fashion, which we'll demonstrate again later. Once the IV is secure, we want to remove the tourniquet. And we want to add, make sure we got good flow, either with a flush or IV tubing, make sure we have good drops in our drop chamber.
All right, we're gonna go over 4 common points of failure on IVs. The first one is going to be your angle. So with your angle, once everything's all ready to go, very commonly we'll see very shallow angles. And it's very hard to to end up where you want to be at too shallow of an angle. Not too steep, right? We're looking for about that 45-degree angle, just so, right? So that's a very common mistake. The next one is traction. Obviously, getting into the vein is very, very difficult without traction. What we see very commonly is that people will pull traction, get ready, and they're right there, they're about to make the puncture, and they'll release the traction and the vein goes away. So watch out for that. Next, two common things that will happen. One, it's very worth noting that the catheter is proximal to the tip of this needle, right? So you can see quite clearly where the catheter is, right up in here. So what that means is that the needle will be introduced into the vein prior to the catheter. So you'll get a partial flash in your flash chamber, and that tells you that the needle's in. If you start trying to advance at that point, the catheter will bounce off the edge of the vein. So you need to put a little bit further into the vein to get the catheter in there, and you'll know that that's happened because you'll get a full flash. So that's something that's very, very common. The next thing is a dexterity issue. So what you'll see very commonly is people pulling the needle back instead of pushing the catheter forward. So you can see here, watch where my tip of my needle is. What we want to do is tip of needle stays right where it is inside of the vein. Catheter moves forward. But what we see sometimes is people who are pulling the needle back, like so. Then you end up with just the tip of the catheter in the vein, and you have to try to float it in, and that's no fun for anybody. So you can sort of see what we're talking about here. We'll see if we can get a good puncture out of the deal, right? So good angle, you go in. Now you see we've got that partial flash, right? Now we just need to go a little bit further and come out the bottom, right? Now you can see where our needle's at because we're using clear IV tubing. Now we can push that catheter forward. You'll notice the needle tip doesn't move, right? And that's what we're looking for. We get a much better flash at that point. What we don't want to do, and you can see what the problem would be, once you're here, if you started moving that needle forward, or moving the needle backwards, I'm sorry, the needle leaves, and you end up with all this catheter showing. And that's something that you don't want, because then you're either going to try to float in, or you're just going to pop out and have this problem. Good. Those are your 4 common problems. Angle, good traction, not getting the catheter all the way into the vein, and moving the needle backwards instead of the catheter forward. Here we are. We're going to demonstrate a live IV. Lieutenant Mesner, Firefighter Werner have graciously volunteered to do this. They're under a lot of pressure because we're videoing them. Here we go, live IV.
Okay. Just like we talked about before, we're going to work on our good setup before we start any IV. So we have identified our patient, we've identified a good arm for this patient. Nice, healthy patient, good arm, lots of good IVs. Get our start bag set up, sprawl it out, and make sure it has everything we need in there, including tape, which has already been pre-set up for us. We have our tourniquet. We have our Tegaderm. Our 2x2 if we need it, and our towel. And our alcohol. Again, we've identified a good arm. We always start up high. Grab that, thank you. Tourniquet the arm above all IV access. So we have lots of opportunity to make it good and tight so we get a good fill of our veins.
So Mesner, tell me what you think about this, but a piece of advice I often give, especially to new providers, is don't agonize over your vein choice.
True. I agree.
Take a quick look and pick.
Yep. Always starting low. If we miss high, it eliminates our opportunity to start an IV low. So we always start low and try and find a good IV low on this patient. And I've identified a decent handcuff vein, but these are good too. Remember, this is a lot more sensitive than up here. So if you have a choice, maybe go on the more tougher skin. But if this is your only opportunity, we'll start low. Okay. Identified the site. We want to make the site clean. So aseptic technique. Nice small circles and come out. So if we are planning on doing a blood draw on our patient at this time, we would set this up as well. For demonstration purposes, we're not going to do the blood draw on Adam. So again, still aseptic. We haven't contaminated it all. I'll open my catheter. I'll inspect my catheter, make sure it's good. I've identified it's good. There's no shear. The bevel looks good. And the actual catheter is loose on the needle. Still have good visualization of IV site. Good technique. I'm pulling traction low on this patient. You can see the skin get blanched out a little bit and actually makes those veins a little more prominent. I come in, I visualize it, come in about a 45-degree angle, get a flash, advance, pulling the needle back, occluding above